Welcome to our second CPCRN Scholars webinar. It is my pleasure to introduce Dr. Sarah Birken on a topic that many of you were interested in hearing about, applying implementation science theories. So she will talk a lot more about this because I know I've had larger discussions in smaller groups with some of you about this topic. As you know, this webinar will just be an introduction. I will give her a chance to do the introduction and presentations and then turn it over to Sarah. And then we'll have Q&A time at the end. And Sarah, if you're open to it, we could also see if you're open to anybody sending you emails or questions afterwards. All right.
Yeah, absolutely. Thanks so much, Com. I'm pleased to be here and pleased to see so many people on today. And I am very open to contact. I would like a clear request is always appreciated in bold font with a due date. This is a topic that is of great interest to me, and I find a lot of I get a lot out of talking to people about it and starting to kind of think in new ways about these topics. So yeah.
Great. Well, before you get started, just to let you know, there are 20 scholars. I'm not sure if everybody could make it today because our first one was really well attended, but I know we're going into the summer months and I've been getting a few out of office emails from some of my emails. But for those of you who are scholars, we have scholars who are students from undergrads to postdoc. We have practitioner who do cancer control research or implementation science researchers. And then we also have researchers. So we have a whole 3 categories of scholars. And for you scholars, Dr. Birken is an associate professor at Wake Forest. She's in the Department of Implementation Science and the School of Medicine, and also at the Wake Forest Baptist Health Comprehensive Cancer Center. Her work that I've seen across the years focuses on organizational determinants of implementation, management and mid-management roles in implementing evidence-based interventions or practices, implementation of innovations in cancer care, and selection and application of implementation science theories, which is why she's here today. She's received funding from AHRQ, Healthcare Research and Quality, the Cancer Research Network, CDC, and the National Cancer Institute. I know she has many other accolades, but I'll stop there and turn it over to Sarah. Thank you so much for coming and talking to us.
Yeah, absolutely. Thanks for having me. And it's good to know that there are a variety of scholars with different backgrounds on. So I'm hoping that you all will help me kind of think about the angle for practitioners. I am a researcher. Some of my best friends are practitioners, but that is not the way my brain works. So I rely on my practitioner colleagues and intermediaries to help me think in more practical ways. Although, I do try to make my work as relevant as possible. Well, I, of course, try to make my work relevant for practitioners, but also try to make the work that I do for researchers as practically useful as possible. So I would love it if you all would kind of pipe up along the way of my presentation and let me know if there's something that can help make this more salient for you, depending on where you're coming from. So I'm going to start by sharing my screen. Let's see if I can do that successfully. Oh, this looks like it might just work. Can you see? Good. And I really want to drag this over here. Oh, no, it's not going to let me, which is kind of annoying. It's on my other screen. That's annoying. So I'm going to be looking over here. Hopefully that won't be too annoying. Right. So I want to start, hopefully this will resonate with all of you actually, taking a really broad scope in thinking about how I come to this topic of selecting implementation theories, models, and frameworks. And so I know that this slide has a ton on it. You don't need to try to read it because we're going to walk through it together. So we're going to start on the right with client outcomes, right? So this is our goal, is to improve. Often, most of the time, our goal is to improve client outcomes. We're trying to reduce morbidity and mortality. We're trying to improve satisfaction. And we are usually facing some sort of problem that is inhibiting our ability to achieve the goal of improved client outcomes. And that problem usually lies with something that is happening with respect to quality of care, the efficiency of care, the safety, timeliness, so on and so forth. So jumping over to the left, we usually come in with some solution. There's some solution to some problem. So I'm going to give you an example from research that I have contributed to, but also just studied other people's work a lot, and that is with respect to cancer survivorship. And the problem that I've been thinking about for a really long time is that a lot of really low risk survivors stay with their oncologists because there just isn't a clear path of care for survivors. And so they stay with their oncologists. They have worse outcomes than people without a history of cancer, and they don't receive recommended health services. And so years ago, survivorship care plans, these documents that were kind of information about diagnosis and treatment and recommendations for care in the survivorship period, were, this magic bullet that everyone thought was going to improve care for survivors. And the long and short of it is, we don't know if it did anything. It probably didn't. We're not sure. But a lot of what ends up happening, a lot of what implementation research ends up being, is thinking, okay, we have this potential solution to a problem, be it a survivorship care plan, or ideally an evidence-based practice. Like, oh my gosh, I am gonna maybe see if I can come up with another cancer-related evidence-based practice, like colorectal cancer screening. We know that's good for detecting cancer. I think that's not my area, but there are problems with the implementation of that screening. And so we need to figure out, okay, how do we get people to get screened for colorectal cancer? And that is where implementation comes in. So I'm going to take a little bit of a tangent and talk about what I mean by implementation strategies and why I think that's kind of a misnomer, but I'll save that for just a moment. So that's where we live. We live in the area of trying to figure out, how do we get this evidence-based practice into the settings where we want to improve upon the problem. So how do we select implementation strategies? This is where I'm coming from when I'm thinking about selecting theories, models, and frameworks. I know this seems like not a theories, models, and frameworks talk, but it is. So here's where I'm gonna take a little tangent and talk about my beef with implementation strategies. So technically, the National Institutes of Health defines implementation strategy, or defines implementation science as the study of strategies to facilitate the integration of evidence-based practices into care. I really don't like that definition, because strategies in my mind are one component of ways in which we try to integrate new practices. In reality, sometimes we need to modify the context to make it more receptive to an intervention. Sometimes we need to refine the intervention itself to make it more implementable. Sometimes we need to, and all the time, I would say, we need to identify implementation strategies that are likely to address the reasons that the intervention isn't being used. So oftentimes what I see in manuscripts and in grant applications, I see people saying, we're going to use audit and feedback. That's our implementation strategy. But there's really no reason that audit and feedback was chosen other than the fact that the investigators are experts in audit and feedback or external facilitation. So that's my beef. And I want you to keep that in mind, that when I talk about strategies, I'm not talking about the ERIC strategies. I think those are too narrow and defeat the purpose. So my little caveat. So we come up with some problem. There's some problem we know there that patients are not getting the care that they should be. We kind of figure out why that's happening. And then we want to address that problem, the reason that it's not happening with specific strategies. And then for better or for worse, what NIH funds is testing those strategies to see whether they improve implementation. So that's kind of the 10,000 foot view. Most of my work has really lain right here in figuring out like why are survivorship care plans, for example, not used. So I'm going to give you an example of a problem that I have studied for a while. And actually, I see Lisa Spies is on the call, which is fantastic because she's done work in this area too. And this relates to the management of patients with low risk microscopic hematuria. So this is invisible blood in the urine that may be an indication of some sort of cancer. But if you're very low risk, it is very unlikely to be a cancer. And if you use CT to evaluate those patients, you're actually exposing them to a dose of radiation that not only is unnecessary, but may actually cause more cancer than it detects. So we know from our preliminary studies that despite the change in guideline to say, if you're low or intermediate risk, if you're a patient with low or intermediate risk and you have microscopic hematuria, you should not get scanned. You should not get a CT scan. People are still getting CT scans inappropriately. So that's kind of work that I tend to rely on other researchers to produce evidence of some issue. And in this case, this example that I'm going to thread through is persistent use of CT for these patients who are more likely to be harmed by CT than benefit from detection of cancer. Okay, here's where we get to theories, models, and frameworks, my favorite topic. So why is this happening? This is crazy. When I heard that that CT, that it's called a urogram. I'm not a clinician, obviously, because I can barely speak the clinical language required to describe the problem to you. But I have clinical colleagues who do speak that language. Why, if it's contributing to more harm than good, why are urologists continuing to use CT? That's crazy. So what Lisa did in some of her work, and what my colleagues and I are picking up based on her work moving forward, is to try to figure out, okay, well, why are they still doing this? Lisa did her work prior to the change in guideline, and so we pick up after the guideline. So, we know guidelines don't often change care, so we're trying to figure out what is driving care. If clinicians aren't reading the guidelines like we would like to pretend they all do, why are they continuing to provide care in the way that they are? And the goal here is to really cast a wide net to understand all the potential things that drive human behavior, which is a tricky thing to do. But that's where frameworks are really useful. So what is a framework? A framework is hopefully you're familiar with something called the CPHR. It's okay if you're not, that's not a big deal. It's just a commonly used implementation framework. And that you can see is depicted in here. Basically, the CPHR proposes that these 5 domains, I don't know if you guys can see my cursor, I'm like waving it around the blue circle. These are things that are thought to influence implementation, and they lie in these 5 categories. And those 5 categories have lots of constructs. So for example, in outer setting, you can think about things like guidelines. That's a thing that comes from outside of a healthcare organization and that providers are supposed to read and organizations are supposed to implement. And maybe there's reimbursement policy that's also in the outer setting. And then there's things about the actual intervention. So like thinking about let's call the intervention the guideline itself. Like, what is it about the guideline? Do people not like it? Is it not based in evidence? What is it? Inner setting is like, you know, what's the culture like in the organization? We've all worked in organizations where, well, I guess nobody really loves change, but where change just feels really hard. And there are sticks in the mud who don't want to change the way they're doing things. And the organization is just not set up to accommodate change. Or some places where things just seem to get done. And there's a culture of, we're in this together, we're going to get this done, we're going to do our best, that sort of thing. The process of implementation is like, how is this all going? Like, what are the methods being used to get the guideline into place, for example? And then there are individual and team characteristics. And this, I'm going to do a little pop out. No, I must have deleted it. Within here, the individual team characteristics, my colleagues and I have done some work to say, the CPHR is great for thinking about like all of the potential things that might influence implementation, like everything under the sun, but it does a really particularly bad job with individual provider characteristics, how those influence implementation. So there's this framework called the theoretical domains framework. Well, that's probably not the right link. Anyway, you can Google CPHR plus TDF and it'll come up with a systematic review that we did talking about the combination of these 2 frameworks. But it kind of goes beyond the CPHR's collective level view of what might influence implementation to the individual characteristics, because it synthesizes 33 psychological theories about determinants of behavior. So things like motivation, beliefs about consequences of engaging in a particular behavior. This is getting very much into the weeds, but the point is that going back, we really want an aerial view of the forest. What are all the things that might be going on that might be influencing whether or not a provider uses CT for this patient who is at very low risk of having a cancer? And so doing all that work to figure out what are those things. And the CPHR and the TDF are really good frameworks to just think as broadly as possible about what might be going on. I'm gonna scope out a little bit and use some slides that my colleague Per Nielsen developed to talk a little bit more broadly about what theories, models, and frameworks are. But I realized that what I just talked about was pretty in the weeds, and I want to make sure that I haven't totally alienated all of you. Do you guys have questions at this point, or should I just proceed and maybe you guys can kind of like let it marinate while I talk? I'll follow your lead. Okay. I'm going to take no news as good news, but please feel free to pipe up if you have questions. Okay, so theories, models, and frameworks. Theories, I'm just talking about theories here, just theories. Theories, models, and frameworks are like shorthand for, that's an umbrella term. And theories are unique because they explain why and how things happen. I just talked about frameworks, the CFER and the TDF. Those just say what. What are the things that might be going on? It doesn't say why those things might influence implementation or how those things might influence implementation. It just says they do. Theories say why or how. For example, I don't know, reimbursement might influence implementation. We sure can make up a story, but it's really useful to have a theory that lots of people use and think about and contribute to and refine to explain why. And related to that, why it's useful not just to kind of make up your own story about how or why or what might influence implementation is that we want to accumulate knowledge across studies. So I might be studying the use of CT for the management of microhematuria, and Sue might be studying the use of active surveillance for prostate cancer survivors. But if we are using a common framework or theory or model, we can start to accumulate knowledge about what is influencing implementation and how the intervention that we're looking at might moderate those relationships. It also means that we can kind of start to refine these things based on empirical evidence of what's actually happening in practice. Because I think I'll display at the very end my favorite quote about theory, which is from George Box, who said, "All theories are wrong, some are useful," which is to say, we don't think the theory is right. It's just our best guess right now, but we can better anticipate what might be going on, better understand phenomena if we can refine it based on our collective efforts to integrate our knowledge based on multiple studies. Oh, and we're explicit. We're really, it helps us be explicit about what we think is going on. So this is like, for those quant people out there, you'd never submit a proposal for a quantitative study with inferential statistics without a power analysis. You want to be able to say that you can actually definitively answer your research question. Theories, models, and framework offer a map for saying, here's what we think is happening. And you can go back to it and say, well, we were wrong. What we thought was going to happen, what the theory said was going on, is actually incorrect. Or, hey, we found support for this relationship, for example. So Kurt Lewin said there's nothing so practical as a good theory. I couldn't agree more. But Pear says, okay, Kurt, which theory should we choose? This is the tricky part. People have a really hard time choosing theories. I do too. It's getting easier with practice, but the kind of spoiler alert, there isn't a really great algorithm for choosing theories, but hopefully with a little bit of understanding about theories, models, and frameworks, you'll be better prepared to choose one that works for you. And that's the goal. Not to just have something to have something, but have something that is useful to you in your work. So again, kind of reviewing here, but theories predict, they explain how and why certain things may influence implementation. Jumping down, we already talked about frameworks. It kind of says the what, it identifies factors that might influence implementation, for example. And what we haven't talked about are models. And models describe or guide the process of translating research into practice. So I think about logic models, for example, it's just kind of a schematic of being like, X happens, and then Y happens, and then Z happens. And it doesn't necessarily say how or why, but it kind of talks about a sequence of events. It's important to know, again, that theories explain mechanisms of change, but models and frameworks don't. And that's important for selecting strategies as a little teaser. Okay, so this is another busy slide. Pear uses the term theoretical approaches to mean theories, models, and frameworks. And then he kind of breaks them down. This is kind of a tool for trying to understand how to select theories, models, and frameworks. So let's see what I'm just going to put everything out. Okay, so describe or guiding the process of translating research into practice. These are process models. A good example of a process model is EPIS, that it's exploration, preparation, implementation, sustainment. This is kind of the process by which evidence is integrated into practice sustainably, as just an example. And then evaluation frameworks are like, okay, we implemented something. How did it go? Was it implemented? In what way? And then to understand what influences implementation and other implementation outcomes, we have 3 categories. And again, this is review. This is, again, we've got determinate frameworks. That's a menu. You pick and choose. It says what is influencing implementation. We have classic theories. My favorite happen to be from organizational theory, but as I mentioned, the theoretical domains framework uses psychological theories. Again, these are theories that predict implementation. And then there are implementation specific theories. So I don't know how many were developed in the field, but I know Brian Weiner, for example, imported from the field of manufacturing the innovation implementation, the theory of innovation implementation from Klein and Sora. And these are specific about implementation. Okay, so I think I've kind of done due diligence here. I won't go into this study that I have up here. Suffice it to say, I've done a lot of work just asking people why they do what they do. In this case, it was, why do they use survivorship care plans? Okay, so now we're shifting from, okay, in the case of ideally what's going to happen in my hematuria study, we're going to say, okay, we figured out why people are continuing to use CT imaging for patients who are more likely to be harmed by it than derive any benefit in the form of cancer detection. We have some subset of constructs, and they form a kind of constellation. So I don't have study results yet because we kind of just started with this hematuria project, but let's just take a hypothetical study where we identify 4 constructs that are influencing implementation. I don't know what this would be, and it's very unlikely that it would just be 4 constructs, but maybe these are the 4 most salient constructs. These are the difference makers. In the parlance of quantitative methods, these would be the statistically significant determinants of implementation. So these are the things that are really difference makers with respect, like this is what is impeding implementation of our hypothetical intervention. So that's really important to know what those are, so that instead of saying, we're going to try to implement, the new microhematuria evaluation guidelines with external facilitation. That is really imprecise. we don't know that external facilitation would address these concerns. For example, if these are the key determinants of the implementation of the guideline. I suppose insofar as external facilitation improves implementation climate, or it changes accreditation or patient flow or knowledge, great. But to the extent that external facilitation or audit and feedback or financing or name your favorite implementation strategy, insofar as those don't address determinants of implementation that we identify in preliminary studies, those implementation strategies are extremely unlikely to work, which makes it unsurprising that we have very little evidence of which implementation strategies work. And the reason we likely have very little evidence of which implementation strategies work is because it depends. It depends on the intervention and it depends on the context. All contexts are different and each intervention is likely to have unique characteristics that influence its implementation. So this is, again, just like, this is, I'm summarizing what I've already said, which is strategies should be theory informed. We need to kind of think about what the determinants of implementation are, and then choose strategies based on what might address those determinants. And I'll talk more about that in a moment. You can use, psychological theories, as I've talked about, and you can use organization theories. And I won't go too far into this for now. So how do you identify strategies that are going to address the determinants that you've identified? There are several ways that you can go about this. There's something called implementation mapping that Maria Fernandez from UT Houston and her colleagues have developed. There's a great paper in Frontiers in Public Health that talk through this method of implementation mapping. It is a theoretical process. For better or for worse, the theories that they use are all psychological in nature. And so I'm helping them out to kind of think about how organization theory could be helpful in implementation mapping. The behavior change wheel is actually very similar to implementation mapping. And word on the street is there have been efforts to kind of join, get everybody together. And since these are such overlapping methods, come together as a team, but that hasn't happened, unfortunately. But again, behavior change wheel, it just kind of crosswalks determinants to strategies. So a very simple one that I think of is knowledge. If you don't know about a guideline, educating people about a guideline is a good strategy. Of course, it's not always that simple, and there are so many different constructs, so many different determinants of implementation, and the kind of constellation influences what strategies you might use. But a straightforward way to think about it is the strategy is something that is going to influence the determinant. It's going to change the determinant to position the individual or the organization for optimal implementation. The Center for Implementation is an excellent organization out of Toronto, where they have, it's all, it's not free. You have to sign up for courses. I strongly recommend it. They have some tools available for going through this process. A lot of people find implementation mapping and the behavior change wheel to be a little bit disorienting sometimes and a little bit complicated. The Center for Implementation breaks this down in a really nice way. And then we get into the final phase, I guess, which is testing the strategies. So I'm going to give another example from my research. which is I developed an intervention using intervention mapping, which is kind of the mother to implementation mapping. So instead of developing implementation strategies or identifying implementation strategies, you're developing an intervention to facilitate transitions of very low risk breast cancer survivors from oncology providers to primary care providers, which guidelines recommend. And as as I kind of hinted at before, with respect to survivorship care plans, this research comes out of a long, a long history I have in studying how can we get survivors, how can we optimize survivorship care. And so this proposed study that I'm going to be doing, submitting an R01 in October, yay, is based in the knowledge that we don't know whether this intervention called START is going to be effective in improving care for survivors. The other thing we don't know is whether or not oncology practices are going to use it. That's a big deal because it does not require specific training in implementation science to know that if you do something poorly or you use something poorly, it's not going to work very well, which is what we saw over and over again with survivorship care plans. There was huge variation in the quality with which they were used. Sometimes it was like this elaborate process of sitting down with a survivor and really tailoring it to the survivor and calling the PCP and doing a handoff visit and all of this. And sometimes it was literally a sheet of paper in the survivor's electronic health record or health record. Obviously, if you're sitting down with a survivor and you're calling their PCP and you're getting everybody on the same page, it stands to reason they'll probably end up with better care than the person who just has a sheet of paper that they don't even know about in their record. So we're applying that same principle to this study to think about the moderating effect of implementation success on the effectiveness of the intervention. So, if the oncology practices are doing a good job integrating START into their practice, it's potentially going to be more effective in those practices than it is in practices that just don't have the wherewithal to implement well or whatever it is. So that's a hybrid study. Okay, so another spoiler alert, I have no good advice about selecting implementation theories, models, and frameworks. I have some imperfect advice. You can go onto this Implementation Science Exchange at UNC and access this thing called TCAST. And originally, I really wanted this to be an algorithm where you could go in and like put in determinants and you could put in the level, are you primarily interested in the organizational level or the individual level or whatever, and it would spit out a theory, model, or framework. Wouldn't that be nice? There's something similar to that that is great in theory, but I feel comfortable saying with all due respect to the brilliant people who developed it, who acknowledged this challenge, dissemination-implementation.org was developed by Borshika Rabin and Rachel Tabak. And it's really cool. You can go in there and you can do exactly what I just said, but it's only as good as the theories that are in there. And turns out you probably need a human, maybe not, but to do the thinking about what's going to be most appropriate. And so TCAST kind of takes you through the human component of this question. So this is a terrible slide and I'm sorry, but these are the domains. These are the things that you should think about when you're trying to select a theory, model, or framework. Probably the one that we think about most often is applicability. Like, how relevant is this to my topic? Familiarity is like, it can be useful to import a new theory, model, or framework from another field, not to the extent that it disorients people and is not familiar to them. Usability speaks to the question of like, is there a schematic, like a diagram that kind of shows you what it's saying? Or are there, the CFR, for example, has a wiki and it has interview guides and, you know, different tools on there that help you use the CFR, and that's cool, that's useful. And then when you're talking about theory, maybe you want it to be testable. If you want to be able to test a theory, you need to use a theory, not a model or a framework. So it's imperfect. Check it out. If it's useful, great. If not, don't worry about it. We're still working on it. But practically speaking, I think my advice is this. Think about, and these slides are wrong, I'm sorry, the slide call outs here. But just think about like, what are you doing in your work? Are you trying to facilitate implementation? Are you an implementation practitioner? You probably want a process model. And if you want to kind of select strategies to facilitate implementation, you probably are in theory territory. And if you're really kind of trying to figure out what's going on, either on the front end, anticipating the problem with implementation, or thinking about what happened with implementation, like often, why did it go so poorly? Then you're in framework territory. Now within those categories, which one you choose is a big question mark. I think I failed to mention that there are, some counts say like 60 implementation theories, models, and frameworks. And others say there's like 120 or whatever, but there's a lot. The point is there's a lot. So I think all I would ask you to do is just be thoughtful. And TCAST, I do think, can help with that, just to justify why you're choosing a particular theory, model, and framework for your work. I am not above Googling. There's no, I have lots of times entered into Google, like the relationship between whatever. I'll give this very convenient example because there is something that would pop up. What is the relationship between implementation climate and implementation? Turns out there's a theory for that. Brian Weiner has a theory of, is it implementation climate? I think it is. So that's great. But oftentimes it's a little bit less straightforward, but you're studying like determinants of colorectal cancer screening. And you can look at other people's research and look at what frameworks they've used. I beg, borrow, and steal all the time. In fact, that's how I came upon the theoretical domains framework. I found some work that was being done in Europe and around implementation, and they, for whatever reason in Europe, they use TDF more than they use the CFR. In the US, we use the CFR more than we use the TDF. And I was like, okay, this is useful. You can also just talk to somebody about what the phenomenon is that you're interested in, and ask them for advice about whether there's a framework that may be useful. Okay, really briefly, because I know we don't have super long, I'm going to talk about applying implementation theories, models, and frameworks. And I attribute a lot of this work to Alexis Kirk, who's now at Centerstone, but was at, she was trained in health policy and management at UNC. So Alexis did this, systematic review of the use of the CFR and found just a huge number of studies that said we used the CFR, period, end of sentence, no more about the CFR. What's the point? I mean, sure, we're expected to use theories, models, and frameworks in implementation research, but unfortunately, that kind of edict that we are all aware of has resulted in some very superficial theory use. So this little thing I have up on the slide is from a program officer who talks about having received specific aims to review and it literally said insert theory here. Like the people were just gonna like find a theory and put it in, but it had informed none of their work. The reason I care so much about theories, models, and frameworks is because I really believe they can be useful. And so I'm going to talk about how to do that. So the first thing that you can do, it's super easy, is just justify why you're using the theory, model, or framework that you're using. And TCAST can help with that. And then you want to integrate the theory, model, or framework all throughout your project. So there are some people here who have taken my, when I used to teach at UNC course. You guys can just like shut down, don't think, because I pounded this into your brains. But the idea is, you know, you should be integrating that theory, model, or framework. It's the backbone of your project. So I'm going to go through each of these really quickly. We're going to skip this one because it's so rarely done. A lot of people in other fields kind of have a theory that they're interested in, and they're like, huh, like that's an, let's kind of apply this to some practical project. And they come up with a research question based on a theory, for example. That doesn't happen much for us. This is guys, my slides, I need to update them. This is a lot and probably not super helpful, but listen to my words when I say just using a theory, model, or framework to guide the study design. Are you evaluating what happened with implementation? Then you kind of want to have this retrospective data collection using a determinant framework. If you are doing a prospective implementation project, you have that process model to kind of guide the collection of data along the process of implementation. My favorite place, this is where I shine, this and analysis of data, but using a theory, model, or framework to drive data collection. I talked about CPHR having a wiki. It has interview questions, I think, but really for any type of data collection, you should be mapping your data collection onto the theory, model, or framework. So for example, if you are using the CPHR to think about determinants of the implementation of the American Urological Association's guideline for the management of hematuria, you want your interview guide to map onto the CPHR and the TDF in the case of a lot of my research. You can do the same thing with survey questions, making sure that survey items tap the constructs in your theory, model, or framework. A lot of the work I do some mixed method work. And so a lot of the time I'm trying to identify variables in secondary data to represent a construct in my theory, model, or framework. So I'm being very strategic in my identification in my data collection to make sure that I'm gathering all the data I need to answer the question based on the theory, model, or framework, so that I can support or refute my hypothesis about what is influencing implementation, for example. So here's an example. I create these tables all the time where I'm mapping the interview question onto the construct. So I think this is probably, the constructs are probably from the theoretical domains framework. This is just an example. Survey, right. The survey item on the left, I've got this construct on the right. That way I know I'm gathering all the data I need to answer my research question. Data analysis, you get a code book. So this is, we actually used the ERIC strategies to code information about the use of, I don't even know what guideline this was, but so literally in, I think this is Max QDA, that's a qualitative data analysis program management software. These are codes that we are applying to the qualitative text. You can think about, you know, does the theory propose an interactive effect of, X variable on this other variable? Then we need to have an interaction term in the regression analysis. And thinking about which variables to include in the analysis so that you avoid having a kitchen sink model. The variables you include in your regression analysis, for example, are all thought to influence the outcome of interest. And then you can kind of think about, well, what does the theory, model, or framework say about the way things should have gone, how implementation should have gone under these circumstances? And you can kind of have a touchstone. The theory, model, or framework can be a touchstone for thinking about, do our findings make sense with respect to what other studies have found that have used this theory, model, or framework? I'm going to skip this because we just don't have that much time. But my favorite quote from George Box, which I said before, but this is my quote on the right. Theories, models, and frameworks should not be an albatross around your neck. They should give you wings. Okay, I want to acknowledge my colleagues here, and I'll keep this screen up just in case people want to point me to a particular slide, but I'm really happy to answer any questions or whatever you want to talk about with the last 8 minutes. Sorry, I ran a little bit long.
Well, thank you very much, Sarah. I think that was very helpful. I kind of like your steps, and you also introduced a couple of tools and websites for people to go to, or articles, which I think is also very helpful.
Yeah, sure.
I will ask one of the coordinating type things is if we could get a copy or a PDF of your slides just for everybody to have as reference. And then of course we have the recording as well. Just because of the time, I want to turn it over and allow people to ask questions for Dr. Birken.
Hi, Dr. Birken. I have a question. First of all, thank you so much. This was extremely informative.
Good.
So my question is a very simplistic one. As someone who is new to implementation science, I totally understand the strategy behind being deliberate in the selection of implementation strategies. What would you advise someone who is new to the field? Like, what is the best way to become more familiar with the different implementation strategies? Because it seems like there's a lot and some people have certain preferences. So how would you go about it if you were like me, new to the field?
Well, I'm going to give an answer that is probably one that most people wouldn't give. So take it with a grain of salt, because I have a big chip on my shoulder with respect to implementation strategies. I don't recommend becoming familiar with implementation strategies. I recommend becoming familiar with frameworks. And then, I think a good place that I would dip my toe is start out with, if you Google the behavior change wheel, that's a really great, they have strategies embedded in them, and those are mapped back onto determinants, psychological determinants of implementation. So it's this crosswalk. Another related term that you could Google to help you kind of start to think about this stuff is COM-B. It's COM-B, and it stands for capability, opportunity, motivation, behavior. This idea that capability, opportunity, motivation influence behavior, and that determinants all fall into the capability, opportunity, or motivation domains. And what the behavior change wheel does is say, okay, you've got a problem with capabilities, we're going to do XYZ strategy. But I think that getting to know individual isolated strategies is unfortunately the way we typically do things. I think it is not as useful as thinking about when those things are needed, when any particular strategy is needed. I also think that repositories or lists of strategies are too narrow. So they don't take into account the kind of refinement of the context or the intervention or the strategies themselves to help facilitate implementation. Yeah, I'm looking at this article. Yeah, that's great. Behavior change wheel. So yes, in the chat, Jessica included this. This is a great reference. And there's just a huge literature on the behavior change wheel, Combe, theoretical domains framework. And I think, you know, if you're interested in using the theoretical domains framework, if you're a researcher, it's so great. They, Lou Atkins and her colleagues wrote up an article telling you how to do it, which is so useful to, like, they give you instructions how to use this framework. And so I see that Emily asks, while there may not be a great way to pick a strategy, are there any specific pitfalls to be aware of? Well, you know, part of what got me onto this research agenda is I was interviewing somebody for an unrelated project, and she is an implementation expert. She's renowned in the field, and she attuned me to this phenomenon that I had never even considered before, which is that when we apply implementation strategies kind of seemingly at random, or just kind of because we're an expert in them, or, you know, common sense suggests that they might work, or we just think they're really powerful implementation strategies, if we don't have a really good reason, and I would venture, if we don't have a really solid theory about why or how the implementation strategy might work, we are burdening busy practitioners by throwing spaghetti at the proverbial wall, by saying, we think audit and feedback might work, but in fact, you know, a determinant of implementation that would make audit and feedback relevant is, you know, an awareness of current practice behavior. But if lack of awareness of current practice behavior isn't a concern, that's going to be, it's really unlikely that audit and feedback is going to improve implementation. So I think common pitfalls are choosing strategies that are convenient. I think at the very least, you know, a very, one simple way to go about it is just to go to the stakeholders involved in the work and say, what's going to help you do better? That's an ideal way to go about it if we could explain why we do what we do, but we're humans and we're just so unpredictable and irrational that we have a really hard time explaining why we do things that we do, which is why all of this elaborate research is needed. I don't think I really answered your question, but I tried.
You did. That was very helpful. Thank you.
Great.
Sarah, so I have a practical question, and it relates to what you were just saying. I can guess, I think about who you interviewed about implementation strategies, but in terms of applying theories, you know, some of them, like you mentioned, have, like CFR, has so many constructs and domains. Do you have any practical tips for, like, going from the constructs definitions to applications, like in choosing an implementation science theory or model? What are some things that people should consider in doing that? Like from turning the constructs and applying them in a survey, perhaps.
Oh, yeah, yeah. So whether or not they're kind of established measures for the constructs.
Yes.
Yeah. Ooh.
Or whether to use them all or any, or how to approach that.
Oh my
too.
Goodness.
Yes, yes. And any
question.
tips for that?
Yeah. So the short answer about, like, quantitative survey items, there, Brian Weiner and Carol Lewis and some others have really tried to develop measurement tools, measures for I think like acceptability, appropriateness, and feasibility, I think they have, but there aren't any others for any other kind of implementation related constructs, which makes it really hard. So we're all kind of doing the best that we can. There may be some existing ones out there, whether or not they've been validated. I don't know. Choosing among them, yeah, really. I mean, if you're collecting your own data, whether it's an interview or a survey, you really have to be judicious, right? In what questions you're asking. And if you were to ask a question about every single construct in the CFR, not even leaving alone the fact that I use the CFR and the TDF, which blows up. I mean, so for interviews, because so much of my research is qualitative, the simple answer to your question is I ask a very broad question about their use of the intervention and about kind of what's going on and how did they get to doing it the way they do it. And then I use the constructs, or at least the domains, as probes so that they may go off and be like, what? I don't have the resources I need. And they may spend half an hour talking about resources. Hopefully I could reel them back in and say, well, tell me about, like, have you ever had, what is your experience using this intervention before? Like, did it go well? Did it go poorly? So I'm kind of nudging them in the direction of thinking about other domains that may be influencing their behavior that they might not be top of mind for them, but may actually be very influential in why they're using the intervention or not. And Lisa Spies, again, developed an interview guide, which I have used a bajillion times now and refined, that gets at that basically does this work of a broad question and then probing based on the domains and constructs. And remember, with a framework, you get to pick and choose.
Great. Well, thank you so much. I want to be mindful of everybody's time. Thank you, Sarah, for not only the presentations, but the great tips that you had and all the tools and resources. I hope everybody has taken away a few strategies for selecting and applying theories. And we hope to see you at future webinars. Thank you again, Sarah, and we will talk to everybody soon.
All right. Thank
and
you.
Thank you, Lisa, too, for having a tool.
Yes.
Let us know if it's easily accessible, if you guys don't mind.